It's nice to have the opportunity to speak to all of you who are watching today. I go by Randy, that's my nickname. My real name is Edmund Howe. I'm a psychiatrist, and I've been at the Armed Forces Medical School, which is known as the Uniformed Services University of the Health Sciences, or USUS, in Bethesda, Maryland, and I've been teaching ethics here since the first year class first came to USUS in 1977. I'd like to first thank Dr. Simmet for giving me this opportunity to share with you some of the ideas that the military medical students at this university think over and mull over every year. The topic for my presentation today is the ethical responsibility of physicians in the care of enemy combatants. To prepare you for that specific topic, I'm going to talk about some of the big issues in military and medical ethics that have existed really since 1977 to set a background for going on and discussing some of the more current questions that have arisen since 9/11. Let us first talk about what the controversy is all about here. It's one that's obvious to all of you, I'm sure, but it's worth tagging before we begin. And that is, how is it different for military care providers as opposed to civilians? Well, obviously, the mission of the military in some contexts, when diplomacy doesn't work out, is battle. And of course, the outcome to soldiers and enemy soldiers can be their death. Doctors' normal course is, of course, to further the sanctity of life. So those are pretty much opposites that military care providers must contend with. Now, some organizations centuries ago have said that, well, to avoid the doc being in a double bind, being in the military whose mission could be to take life, and docs whose primary mission is to save life, maybe military doctors should be neutral, such as all being in the Red Cross. Well, that has some pluses and some minuses we won't go into right now. You can perhaps imagine what they would be. It's a sort of interesting discussion, and persons discussing this battled it out. But we'll simply note that as a way of tagging the chief dilemma going on here before we go further. What is the rationale for docs being in the military and serving in the military? Well, assuming that it's a fair or a just war, that should be, one's forces need all the medical care they can get. One need merely pick a war such as World War II and the importance of preventing genocide to make that point. Now, what is one of the practical concerns that comes up here in deciding what policies to implement? Well, a big question is who should decide. In theory and reality, the military serves the greater society. So fine, the greater society should decide what ethically military docs and the military can and should do. But there are questions as to how do they decide that on an ongoing basis. And typically, what the government does then is it has administrative bodies who carry out and implement the policies that others, Congress and the President, enact. Well, there's a distrust that sets in there, which is as follows. People in the military at the highest levels are likely to say, well, civilians don't really understand some of the real issues we run into at the front, and so they're going to make decisions according to ideas that they have, and that's fine, but they may miss the boat in a way which is seriously problematic. On the other hand, civilians say, well, the military personnel at the highest levels may have their own bias which is a military bias towards furthering the military missions, even at the expense of certain other important ethical concepts and values that should be on the table. So we'll return to that issue of who should make what decisions when. Now, let us begin with some of the specific ethical problems that military physicians can run into. And we'll start sort of basic and work down to more and more specific. When soldiers are injured in combat, and they come out of combat with whatever it is, and the care provider treats them, and then they return to combat, docs are implicitly doing something quite different than what they do when they're treating civilians in civilian settings. That is, they're implicitly being a chain in the link of events that could lead to the soldier's death. That is to say, the soldier is not going to a bed to get well. If the soldier is well enough, the soldier goes back to duty, and the soldier may get killed. The decision of who goes back to duty when, with what sort of injuries, is actually made by the commanding officer, and so technically the military care provider is healing the soldier, and then it's up to the commander to decide, based on how the soldier is, whether the soldier should go back to duty or not. There have been some classical times, such as during World War II, where soldiers, even though perhaps having a temperature, went back to fight because they were needed there, so that it can be that even with some degree of illness, the soldier might be needed at the front. That's the commander's decision. What's the justification for military care providers possibly being a link in the chain that leads to the soldier's death? Well, as we said before, if it's a just war, the end here justifies that. If one again thinks of just World War II and genocide, that's a self-evident answer. In the military, representing that fundamental difference is something called the military medical triage principle. And what that says is that military care providers have two priorities. One is to further the mission of the military when necessary. That's what the military is all about, winning wars when necessary. The other is to do the greatest good for the greatest number, which might come out to be saving the greatest number of soldiers' lives or to save soldiers from serious injury. The second of those priorities you will recognize is very similar to civilian doctors during disasters. That is, they may abandon the traditional notion of treating those individuals right before them that are injured worst and in most danger of, let us say, dying, to be able to treat more people and save more lives by treating those with lesser injuries because they can treat greater numbers. Now, this conflict between saving the most people and furthering the mission that potentially exists has come about sometimes. I'm going to give you one example, my purpose being that you can get clear on the principles in conflict here, just as all of you studied physics, I imagine, and then you recall there were billiard balls on a frictionless plane, and you were trying to figure out what angles they'd go off at. Of course, in reality, there was no frictionless plane. So in the same way, we're looking at a specific example to get clearer, as clear as we can be, about the principles that are in conflict. This happened during World War II. Penicillin had just been invented. It was just going out in minor amounts to military doctors and others to treat infections. And there was just a little bit that military care providers had during World War II. They had some injured soldiers, some of whom were dying from their injuries. And it looked like penicillin could save their lives. Now, as it happens at USIS, often there are military physicians who've been in the military a long time or a long time ago. So I've had the fortune of having some of these people who were there in World War II at the time share with me their experience with penicillin, and military care providers were very unsure how they were to use it, what sort of doses to use, and so on. Perhaps worth keeping in mind. Well, the Germans were also pursuing the war, and in one of the medical facilities, there was also a great need to treat a number of the soldiers who had venereal disease, which interfered with their being able to fight effectively. They needed penicillin too. Who should get it? Those who were dying without it, or those who had venereal disease so that they could then go on and carry on the fight? And this was not, well, it would be nice to have them carry on the fight. They were desperately needed, I'm told. So the decision was made, and there's some academic debate about at what level this decision was made, and it was made to treat the soldiers who could go back to the front. Some of you might say, perhaps that was justified because otherwise everybody could have died if the medical facility was overrun, and that theoretically is a fair enough position here. But what it illustrates is how that conflict can work. Well, one thing I'd like you all hearing this to know is a subtle point that might not be self-evident, that serves to give some sound rationale to what happened at that time in the military. And this involves the principle of equity, or treating people equally, or some would say justice, though keep in mind that justice can have very different meanings. It can mean treating people equally, the principle of equality. It can mean treating people fairly. In the law, treating people fairly is giving them due process, allowing someone to examine witnesses if someone is in court. That's not the meaning we're referring to here. Here we're referring to equity or treating people equally. Now, when people come into the military, they agree, at least implicitly, that they may, if necessary, give their life for the greater society. That's what soldiers acknowledge when they come in the military. That's why we owe soldiers as much as we do. They're giving their life, potentially, for us. Well, the question that arises here ethically is, at what point is a soldier taken out of that contract, where he or she no longer might give their life for the greater society? One might think it's once one comes from combat to the military care provider. But note that it needn't be that way. It could be that even after being seriously injured, one is still in that group of soldiers who may have to give their life for the rest of the society, if that's necessary to win the mission. If you look at that perspective, then those who were dying and needed penicillin were still in that group who had committed themselves to give their life, if necessary, for the mission. So there's that potential ethical justification for putting the mission first in that context. Going on to a more specific example, one that, in my view, there's a fair bit of confusion as people think about it, and that's combat fatigue. Now, these days, battle has changed, to be sure. But over time, and here I refer to World War II and some of the wars since then, when soldiers experienced what was called combat fatigue, now acute stress syndrome, over time post-traumatic stress disorder. It used to be when they came in with combat fatigue, what was learned during World War II was that if docs removed patients, soldiers, from the front and, for example, sent them back to the States, they might develop more severe symptoms over longer time, presumably due to survivor guilt. That is, the soldier might have an injury over in Germany, for example, come back to the States, and then his buddies or her buddies, depending on the circumstance, could all be killed, or some of them could be killed. And the soldier who returned to the States might think, gee, I survived, they didn't, maybe I could have gone back to duty, how come I'm alive, they aren't? And those sort of feelings could lead to permanent psychiatric sequelae. There may be some question of empirically what percentage of soldiers develop survivor guilt and how much worse is it, and so on. But nonetheless, regardless of what the data proves or doesn't, that's been a rationale that military care providers have often adopted as they treat soldiers that come in with combat fatigue with the expectation that they'll be returning to their unit. And then with perhaps 2 or 3 days of hot meals and some sleep, the soldiers are expected to return to combat and often do. That might be different from what civilian docs or care providers might do when the civilian patient comes in traumatized by something that's happened. The civilian doctor might not send those patients back to the scene where they could be re-traumatized and might be afraid of it. A question: what is the ethical justification for military care providers treating soldiers with that expectation when they might not do that as civilian care providers? As I've suggested, the common rationale given for that is that that saves the soldier from more permanent, serious psychiatric injuries such as post-traumatic stress disorder due to survivor guilt. There's a problem with that, however, ethically. That is, if the military care provider said to the soldier, which would you like? To go back to the States, even though you might have more permanent and severe injury, or would you like to go back to combat? The soldiers might very much say, I'll take my chances on going to the States because I'd rather go that way than take the risk of dying during combat. In civilian settings, one would respect a patient's autonomy even though they might have an anxiety or depression syndrome. So that justification, saving soldiers from survivor guilt, might not be sufficient. That would be, in fact, a paternalistic judgment of military care providers of what's best for the soldier, regardless of what the soldier wants for him or herself. That argument, paternalistic judgments, is open to question, though it's important that you all know that all paternalistic judgments aren't necessarily flawed or wrong. Well, is there another justification for military doctors treating soldiers with the expectation of returning to combat? The answer is yes. That is, it was also found out during World War II that if soldiers coming in with combat fatigue are relieved of going back to combat, other soldiers might unconsciously or consciously, for what psychiatrists call secondary gain, might develop symptoms. The mind can do that, so that if you send some people from combat back to the States, it might be that the next day or week there are larger numbers of others, and you might decimate your troop strength and then lose the mission with, of course, the type of results I've referred to before, as in World War II, perhaps genocide. So a justification for military care providers treating soldiers with the expectation they'll return back to duty when they have combat fatigue is to avoid opening up the floodgates so that they can continue to try and win the mission. Another example, preventive measures that military care providers might take that civilian care providers might not, or in fact would not be able to. Example, one that really occurred during Gulf War I. It was feared that Saddam Hussein might use missiles, rockets against our troops with biological agents, botulism, to be sure, in them to decimate our troops. It turned out that with that intelligence, we also knew that we had a vaccine against botulism. Had it been tested against weapons, against rockets with botulism, to see if it would protect soldiers? No. In fact, it would be unethical to ask anyone to be in that sort of experiment, that sort of research, to find out if the botulism vaccine would protect soldiers against biological weaponry using botulism. Well, there were meetings down at the Pentagon and so on to ask the question, should botulism vaccine be imposed on soldiers whether or not they gave informed consent to protect them? If you will, should that paternalistic intervention be required of soldiers even though they wouldn't, if they wouldn't give informed consent? The decision was yes, because otherwise, if many happened to refuse, it again could wipe out our troops. So it was required to take botulism vaccine. Now, what might be the justifications of that? Well, one perhaps worth noting, and one of my purposes here is to have all of you viewing this to be knowledgeable about what some of the strongest arguments are for supporting what military care providers do. And here you will note that there are implicit promises, at least, that both soldiers make on coming into the military that we talked about, and of course because military care providers are soldiers too, that they make in return. Soldiers, as I've said, are willing to give their life if necessary for their country. That includes, of course, other things that they might be willing to sacrifice, such as they may have to wear a helmet if they're out on the battlefield, unlike perhaps people in civilian settings that ride motorcycles. They may agree to be flown in a plane on a mission and to not know where they're going for purposes of security. That may include their being willing to take certain vaccines to protect them, like the vaccine against botulism. Now, why are they willing to make those sacrifices? Because they care about saving the greater society. Now, military care providers in turn make a promise, implicitly at least, to soldiers that they too will share the same goals, so that if it's necessary to have the best mission success, to try to preserve the society by having soldiers take the botulism vaccine, they will support it. So that their mutual promises to each other, soldiers to the society, military care providers to soldiers, support their requiring botulism vaccine even if soldiers don't give informed consent in contexts in which they would if they were civilians. And indeed, for civilians to consent to a medicine, a new medicine, there has to be research showing that that medicine works. not the same necessarily for soldiers, and that's the reason why. Important, perhaps, wrinkle to what happened towards the end of the war, the Gulf War, it became clear that Saddam Hussein wasn't going to use those rockets, and then those on the field made the decision that that decision to take the vaccine or not could be one that the soldier could make. What that suggests is what's self-evident to many who have been in the military. The military goes as far as it can, or tries to be able to give soldiers the same freedoms and autonomy civilians would have, short of compromising the military mission. Another topic that begins to move us into how military care providers should perhaps respond to enemy soldiers who are prisoners, and specifically in interrogations. And what this point is illustrating is both an ethical conflict that's arisen, but also some of the thinking about the limitations of military docs being able to work to further the mission. Though, as we just said, military docs could go along with requiring a vaccine to be used that hadn't been fully tested in research. Okay, let's go back to Vietnam, where our troops were there, and there were civilians in South Vietnam that our military needed their help and support, ideally. We wanted to then, if possible, quote, win over the hearts and minds of the South Vietnamese people to help our troops. The question that arose there is, should military care providers use our medical goods as a means of winning over that civilian population's hearts and minds to our side? Well, one of the ways of doing that was with very dramatic medical procedures such as plastic surgery. So it was seen Vietnamese civilians could see us doing that surgery and maybe be very impressed and want to support our side. The ethical question that arose is, was that use of medicine as a means to this military goal, winning over the Vietnamese civilians' hearts and minds, something that was optimal or ethically justifiable or acceptable? In that context, there were two problems. One problem is that military care providers doing that could be construed, rightfully perhaps, as those care providers using the vulnerability of the civilians due to their medical problems and exploiting that vulnerability for our ends, as opposed to treating them primarily as ends in themselves, as people with illnesses and injuries that needed treatment. And as those of you familiar with philosophy know, that principle that came from Immanuel Kant, that generally persons should not use others only as means to another end, was impermissible. That was the first question. The other question was, if one really wanted to help that patient population medically, one might have said, what would help them most? These same docs treating their infections, treating them for a parasitic disease of some sort, and so on, they might have done something differently. So that issue emerged then. And there were many very severe critics of how military care providers had carried out their medical interventions, not their military interventions, in that context. Now, let's look at that from our view today. There can be two possibilities in that sort of situation. One, military doctors could be treating a civilian population, and they could be treating that population as ends because they basically want to offer them. And yes, an anticipated side effect, if you will, is that that population might look more favorably on the U.S. and its mission. But the military care providers, even in treating that group as ends in themselves, can't separate the secondary gain to our military. And that might seem then as a good thing. Namely, our military care providers are, while in another country, trying to help them to whatever extent they can. Note, however, that at the same time, it could be that their actual intent is the same as it was in Vietnam, to win over the hearts and minds of the civilians. And maybe the fact that the civilians are benefiting, well, okay, that's not their primary goal. Good that it happens, but not the primary goal. Is there a way for military care providers often to know which is which, or for the civilians to know which is which? Maybe not. Maybe those determinations are made at higher levels. So maybe it's a matter of trust for soldiers, military care providers, those civilians, and the rest of the world, whether there's integrity underlying that intervention or there's not. All right, we're now moving into prisoners of war and enemy soldiers who get captured. And here, the triage principle, and you can think of it as an enemy soldier coming in at the same time as one's own soldier. The triage principle says, treat those two equally. Now, there are some military care providers who, for very understandable emotional reasons, have some pain at that, particularly when the enemy soldier being brought in for treatment is one they know has killed their own soldiers, and sometimes they even know the very soldiers that they've killed. Hard emotionally then to give them equal treatment, particularly if they have limited resources and know that one price of treating the enemy soldier is that a U.S. soldier less severely injured may not get treatment. So that's a first problem. Well, how might one look at that situation? One might see the enemy soldier as, at the time he or she becomes a prisoner, as no longer primarily a soldier, because he or she no longer has weapons, isn't at least anywhere near the same degree of threat. So maybe at that time, that enemy soldier is what persons might call a non-combatant, or in ethical terms, primarily a fellow human being. There was a chief of surgery here at USIS named David Burris, who unfortunately died not too long ago, and he used to talk about when he would serve overseas and do surgery, when he would be doing surgery and during the surgery, hold the enemy soldier's heart in his hand in the soldier's chest during surgery. He had a very compelling awareness that he was treating another human being, not an enemy soldier. So that might be a first ethical rationale for treating the soldier, the enemy prisoner, equally to one soldier. There are other rationales. Yes, if the U.S. treats enemy soldiers equally, they might model for the rest of the world the highest ethical standard. Something to be said for that. And it's plausible, whether or not likely, that if we treat an enemy soldier equally, another country might treat our soldiers equally as well. So there are some rationales for that. Now, we also are required legally, under the Geneva Convention, to treat enemy soldiers equally. Interestingly, the U.S. has not agreed to treat civilians who are injured equal to our own and enemy soldiers. Why? Well, the reason was the U.S. was actually trying to be honest and to show integrity in not agreeing to that. The U.S.'s rationale was, gee, if we agree to that, we would, during every exchange, have to have massive resources to be able to treat everybody equally. We aren't sure we can live up to that promise. Well, notwithstanding that, medical care providers try to do all they can, when they can, for civilians. There are indeed some specific groups of civilians who military care providers are required to treat, but sometimes they will try to go as far as they can beyond that. My favorite example that someone returning from the Middle East told me about was a time they found a way to fly by helicopter a pregnant woman to a military medical facility to get the care that she needed. Quite admirable. Well, returning to prisoners of war, yes, there's a technical issue legally, and by technical, I don't mean to bias how you see this, but there's some question of who counts under the law, under the Geneva Convention, as being a prisoner of war. Military and medical people, by and large, don't make that distinction. When the enemy soldier comes to them, whether he or she is technically a prisoner of war or not, to whom the Geneva Convention would apply, isn't something they worry about a great deal nor have time to worry about. They treat. We've talked about civilians, and indeed, if there's a shortage of resources and the law says treat your own troops and prisoners first before civilians, that can cause and does cause much angst for military care providers. They try to do the best they can. Well, there are ways that one could theoretically game the system. That is, one could literally treat prisoners equally and still treat one's soldiers first if one decided to categorize one's own soldiers and enemy prisoners in a large enough group, like all those at risk of dying. Then they could perhaps treat all their soldiers within that group first, because the Geneva Convention doesn't say when prisoners and your own soldiers are equal that you have to choose randomly whom you treat, treating, for example, one's own soldier and then a prisoner and one's own prisoner. And similarly, the Geneva Convention says nothing about when you should stop treatment and go for the mission, as happened in the example we looked at during World War II when penicillin first came around. So there are various scenes that one could come up with, such as making a large category of all those who had equal injuries, prisoners and enemy soldiers alike, and one started treating one's own soldiers first, but was still, in a literal sense, treating them equally to the enemy prisoners, and then somewhere along the way decided to put one's resources into the mission. Well, that you can think about. There are theoretical issues that are interesting, but perhaps not of practical use. Now we're ready to look at some of the issues that have arisen after 9/11, and we're going to focus a bit on interrogations. Well, the classic issue that comes up here is, what about the enemy prisoner who has information of a bomb that's going to go off blowing up New York City? Would it be justifiable to use harsh techniques, using that euphemism, to interrogate that prisoner so that he or she will cough up the information that will save millions of people in New York City? There's two problems that those looking at that situation raise. First, would it ever occur? Second, would those doing the interrogations be certain that the person they're going to interrogate really has that information? And finally, if they use harsh means of interrogation, will the information be dependable? Or will the soldier say whatever he or she thinks will stop the interrogation? There's a huge debate that we won't go into of what good, if any, interrogation does. Most people who have looked at that situation say most of the time it doesn't produce important information. And there are others who say, well, there's this time and that time that it does and has. So we're back to the question of who should decide and how. Note that there's a whole spectrum of interventions that one can address here. We've talked about harsh interrogation methods on one hand. Some say that military care providers and even guards at a prison should not go so far as to become friends with prisoners as a means of getting information that can help the military. Some say even that would be using enemy prisoners as a means to the military's ends, and because of the Kantian principle we looked at earlier, they say that that would be impermissible. So much for the general context. Specifically, there is a range of interventions which have been used, ranging from sleep deprivation in some contexts on one hand to waterboarding on the other. Many people think that that's the continued concern in regard to interrogations. Maybe, maybe not. Maybe we've seen no more of those sort of interventions and those sort of questions. Well, a question that continues is, regardless of what those limits are on what is now permissible in interrogations, there's the question of whether military care providers should or should not be at all involved. Many organizations say military care providers should not be involved at all, even as consultants. On the other hand, there's a strong view that by having care providers involved, they're likely to help as consultants to actually help prisoners by being aware of some, perhaps, interrogators' behaviors which might be unnecessarily traumatic. And therefore, military care providers might be able to help prisoners by limiting inadvertent, overly strong or harsh interrogations, and might even be able to help the interrogators to keep whatever they do within limits which we all can come closer to respect or fully respect. Now, we're back to the problem we began with, of who should make these determinations and how. And I'm going to jump a bit to another situation, namely to Guantanamo, to the prison there, where a number of prisoners have, of course, come and remained in prison there in Cuba. Well, the question I'd like to highlight is the one, who should be released? Now, the notion may be that of, let us say, 100 prisoners, though it has been at sometimes much more than that there may be, after inquiry, good grounds for releasing some of those prisoners. At the same time, it may be known in advance, theoretically, statistically, that a small percentage of that group may rejoin the enemy forces to fight against us. How is that known? Some prisoners who have been released, have fought against us, been killed, and then it's been found out that they are the same persons who were in the prison in Cuba. Well, that raises a number of questions. One is, okay, what risks or what hit should our troops be willing to take for the gain of freedom, if you will, of being released if you're a prisoner? That's a decision where one could say, okay, is 10% risk about right, 1%, or should it be even higher? And again, we have the situation where we must ask who should decide, those with the knowledge, or to a greater extent, the greater society. Well, one of the specific questions that's come up at Guantanamo has had to do with forced feeding. That is to say, there have been some prisoners there who've said they aren't going to eat and are going to starve and, in fact, die. Worth your being aware of some of the competing rationales in regard to this question. One rationale for force feeding those prisoners is the importance of the sanctity of their life, and that is for those taking care of them, not having any part in allowing them to die. Well, if that's the main rationale, one can ask the following question. If you're saving a prisoner's life against, here what would be his will, because all the prisoners there are men, I think still, what quality of life do they have if they're going to live on their entire life there? Is it a life they'd want to continue to stay alive at? And does that matter? For example, what if they have no contact whatsoever with their family? Might they have their life more worth living if they were to be able to somehow have, through letters, however, some sort of contact? I'm raising that to simply exemplify the fact that if you're going to impose sanctity of life over and against prisoners' autonomy, might there be some other gains, such as contact with their family, that should go with that if they can be brought about? The sort of question that all might ask, and particularly military care providers, you all, as you're thinking about this question. Well, what are some of the arguments for overriding their autonomy that go beyond sanctity of life? Well, there are three I'd like to comment on briefly, largely because they all indicate some of the problems that are like the problems we talked about in that argument of giving our own soldiers the expectation they're going to return to combat on the ground of reducing their survivor guilt. We talked about what might be a problem in that ethical argument. Here I'm going to outline three problems with some of the arguments given for overriding enemy prisoners' autonomy at a prison like Guantanamo and force-feeding them when they want not to eat and to die. One of the arguments is that, well, they aren't autonomous because they're pretty depressed. Well, it might be that they're pretty depressed or that a lot are. However, what happens in our civilian hospitals? Can patients who are even substantially depressed refuse certain treatments like forced feeding against their will? Answer, absolutely. Throughout the country, persons, even though significantly, substantially depressed, that's not enough to take away their autonomy to choose. So it's problematic that that argument should work for prisoners in Guantanamo. Second example, well, in our own prisons, our civilian prisoners, we can force feed our prisoners. So applying the same standard, equality, right, that's a ground for having the same policy at Guantanamo that we have in our own prisons. Well, any sound ethical analysis doesn't go from what ethicists refer to as the is to the ought. That is to say, because we do this, it should be that we should do this. That's considered an invalid argument. So we can ask and must ask ethically the question, what is the rationale in our prisons for force feeding? And one of those rationales is to maintain order. Well, one can ask them the question, even if that's a valid ground for force feeding, is that a problem at Guantanamo? And one to make that argument that force feeding is justified on that basis would have to show empirically that that's necessary to keep order at Guantanamo. Now, a third argument is that those prisoners who've wanted to stop eating are not freely choosing that, but rather there are some within the prison who are saying that's what they must do. And in ethical terms, that group, therefore, is acting in a situation of inherent coercion. They feel they must do that for any number of reasons, including possibly fear of repercussions to their own families. And therefore, one must force feed them to not allow them to die due to coercion of prisoners within the prisoner. Here again we have a percent question. Let us say that that's true. We can ask the question, how many have to be coerced to justify force feeding all? For example, if there's 100 prisoners all refusing to eat, if 10 or 10% of those are doing this because of coercion, is that enough to justify force feeding the other 90? You see the question here, and again the question of who should make that decision. Well, I'm going to end here with a couple real findings that I ran into at a visit that I made to Guantanamo several years ago. They illustrate some of the realities, but also a profound point that I'll shortly end on. The first notion is there was some concern of the prisoners there knowing the names of everyone there, the names of their guards. And I'll simply tell you where I went with that. I was thinking of these guards then after their tour of duty down in Guantanamo, coming home to their family, you name where, New York City perhaps again, or perhaps somewhere on a farm in Wyoming. And they're then with their wife or husband and several of their kids. How do they live the rest of their lives? Do they tell their wife or husband and their children that, look, when you're walking down the street in Manhattan or you're in the farm in Wyoming, look behind you. There are some people who've been prisoners at Guantanamo who said they know my name. They will get somehow, sooner or later, me and my family. Part of the reality that may put a tone on all these issues we've talked about. A second thing I'd like you to think about is the ongoing threats that exist in even getting killed at a place like Guantanamo, which of course is something that can exist at our civilian prisons here as well. In our military prisons, optimal care is given to prisoners. Examples would be that many prisoners at Guantanamo get better treatment than some of the civilians in our own country. They are, for example, all given toothbrushes. Well, in a prison, can you make a toothbrush into a lethal weapon? The answer is obvious, no doubt. Of course, you can file it down and make it into a knife-type object which can kill. Well, as a psychiatrist, I was particularly interested in the care that was offered to prisoners for their emotional problems. And I was interested specifically in the question of if a prisoner were depressed, could he respond with the help of a psychiatrist, psychologist, social worker, or a counselor? And the answer is perhaps surprising to you. Perhaps not. The answer is yes. That is to say, a counselor or care provider in a room, even with an enemy prisoner, they might be able to overcome whatever set the enemy prisoner comes in with, and that prisoner might get better from depression. Well, one of the other discussions that we had down at Guantanamo was whether those providing this care, this counseling, should wear some sort of protection, like a guard around one's throat, for example, that could protect a counselor, and by counselor I mean those in the other groups, psychiatrists, psychologists, and so on, from a prisoner perhaps having a toothbrush hidden that had been made into a knife, suddenly trying to stab the counselor in one of the arteries that could lead to their death. Well, there was one care provider who did counseling that I spoke to and asked about that fear. She said, you know, even if I did that, I could easily die in an instant anyway. The prisoner could perhaps get to me, grab this, twist it so that I choke to death, in spite of all the help that would be available. So to me, my life could be in danger either way, but I'm willing to do that. I choose to do that to help these people, knowing of that risk. Just as you might say, soldiers knowingly stay in the military, enter the military in spite of that risk. In my last example of the counselor serving to help prisoners in spite of her awareness of a risk to herself, like soldiers choosing to risk their lives for the greatest society, that's all part of virtue ethics. That is to say that qualities such as courage, selflessness, and altruism may in the end, in most or perhaps all instances, determine what happens, not the ethical arguments that we've looked at. So virtue ethics might be a framework that might be more important than all we've talked about. Similarly, another framework called the care perspective looks at what the relationships are between people and their feelings. That framework might have profound importance also. So as we conclude our discussion of how ethical principles may come in conflict here and how we may look at them, we should keep in mind that that discussion may exist in part because we can use abstract principles to discuss those concepts, whereas they might get much more mushy when we're talking about virtue ethics and the care perspective. What we're saying then in these final comments are then that while the ethical analyses we've been through for most of this may be helpful in some ways, as discussion of billiard balls may be important in physics, ethical analysis also may be very limited in what it can tell us. But what we should do may come down much more to virtue ethics, what our qualities of courage and altruism are, or the care perspective, how we see our relationships with others, even our relationships with enemy prisoners who are human beings. And I'll refer back to David Burris's comment while being a surgeon holding the enemy prisoner's heart in his hand. And on that note, pursue your careers with the notion of all three ethical frameworks coming into play in what you decide. I wish you well in your future careers, and I much appreciate, again, the opportunity to be able to share this with you. Thank you.